Welcome to Navigating Hope, your compass to health empowerment. I'm Dr. Jaime Hope, steering you through healthcare, overcoming overwhelm, personal goals, and emergencies. We'll navigate the healthcare maze with actionable insights and real-world advice, unlocking the secrets to a healthier, more vibrant life. Join us to take control of your well-being and make informed decisions for your health and your future. Stay with us as we unravel the mysteries of medicine, wellness, and life's unforeseen challenges, helping you bypass the ER with a dose of knowledge. Stay tuned till the end of the episode with a recap of your actionable insights and a free gift. Let's chart a course to your well-being together. All right, welcome back to another episode of Navigating Hope. I am so excited to be here today with Dr. Yusko. He is a nationally recognized expert in prolonged exposure therapy for post-traumatic stress disorder, commonly known as PTSD. He's a certified PE therapist, supervisor, and trainer. Dr. Yusko is also an expert in anxiety disorders, particularly with OCD or obsessive compulsive disorder, panic disorder, social phobia, generalized anxiety disorder, and specific phobia. So I think really like everybody on the planet can fall under one of those categories. He's certified as an exposure and response prevention therapist. So I'm really excited, let me finish reading your bio, but to dive into what that is, because exposure therapy can sound very scary. So we're going to make that seem accessible. So he received his degree in clinical psychology from the Graduate School of Applied Professional Psychology at Rutgers, the State University of New Jersey. And as a graduate student, he was supported by the National Institute on Alcohol Abuse and Alcoholism Training Grant under the expert mentorship of Dr. Barbara McCready. Upon completion of his doctoral studies, he joined the Center for the Treatment and Study of Anxiety in the Perelman School of Medicine at the University of Pennsylvania, a fellow Midwesterner who also comes to my neck of the woods in Michigan. Dr. Yusko worked under the senior mentorship of Dr. Edna Foa. I hope I said that right. Thumbs up. For over 12 years and developed his expertise in providing exposure-based evidence-based treatment for the breadth of anxiety disorder. So that can really encompass all of us, and disseminating these treatments to other clinicians. And I love that you're sharing these efficacious practices. So we'll end your bio by saying in 2015, you co-founded the Center for Anxiety and Behavior Therapy, where he continues to serve his community through expert clinical care, offering clinical training and mentorship for local psychology graduate students, and providing educational workshops and professional consultation on the use of exposure-based therapy. That is quite an impressive bio. Thank you so much for being here today, Dr. Yusko.
Pleasure. Thank you for having me. That does sound impressive. It doesn't feel as much, but it sounded really good.
Everybody says that as you're kind of going through, because you did it, generally one thing at a time. But when you look at what you've accomplished, it's really cool. And so I love that you are both treating patients. So you're the direct to individual struggling, but you're also training other clinicians to use these evidence-based therapies, so it just amplifies the effect so more and more people can be helped.
Yeah, that's really the goal of that. It's like I really value the individual work that I do with the clients that I see, whether it's in my office or over Zoom these days. But that's one person at a time. And so when I can, engage a group of, 10, 20, 30 clinicians, then all of a sudden your ability to have an impact across X number of different people, I just really love that ability to be able to have more breadth, in addition to the more intimate kind of personal work of the one-on-one stuff that I do in my office.
Yes, it's more lives impacted. And as people get freed from anxiety disorders and phobias and the bonds of PTSD, it's just a substantial quality of life improvement.
Huge.
Yeah.
This is very accomplishable. There are some really effective mental health treatments that are out there. And unfortunately, we don't have the budgets of some pharma companies to be able to push those things out there to you guys. But I would just like, as a psychologist, to say there are some incredibly powerful psychotherapies that can really address a lot of the mental health problems that are kind of walking around out there.
And it's nothing wrong with medications. However, they are in some ways a band-aid, and you are looking to treat the underlying cause for
Yes.
lifelong, right?
Yeah, we're trying to help folks really develop kind of like the skills to navigate the world with the particular challenges that world presents for the individual. And so when you kind of have a broader toolkit and more tools to pull out, your ability to navigate that world goes way up. And trust me, medicines have been, just like world changing for the mental health profession. And there's still plenty of problems, right? Like there's side effects, not everybody benefits from them. It's just one lane. And then there are, though, other lanes that I just want to make sure people are aware of and know about.
Yes. Well, let's dive into your origin story. So I can tell by talking to you in our conversation before we hit the record button, which are always some of the most fun. You are so passionate about this. You pour into this industry, you pour into this field. So what was this journey that led you into it, specifically prolonged exposure therapy? How
Yeah.
did you how did you end up here?
It's a great question, and probably not that unique in the sense that there's personal connectedness to the passion that comes with having, poured myself into this field broadly speaking. But it really started with more adolescent-based substance use behaviors. And so I grew up in a small town in upstate New York. It's got a famous name. It's Woodstock, New York. And so if you're familiar with, the 60s and the concert and, all of the stuff that kind of comes with that, Woodstock remains this just adorable, cute, artistic town in the Catskills of New York State. But with that comes also, a freedom to explore and experiment and try different things. And myself and my friends all kind of followed in this path. Some of us got through that okay. Some of us did not. And the differences between those that did and those that didn't were not very apparent or obvious. Like, it could have been luck on some level at times. And I had some very personal experiences with substance use and friends and loss and incarceration and so many things. That's what kind of prompted me to pursue the idea of, could we do better by our young people in this area of substance use that can cause so much, just, devastation, to be honest with you, in lives. So that's kind of where the desire to go into the field of psychology started. And so I then got I started at Villanova as an undergraduate, and I started volunteering in a peer program where we started talking to college kids about just harm reduction based strategies to have fun at school, do what you want to do, but let's be thoughtful and smart about it and try to prevent catastrophes from happening. I really enjoyed that and learned a lot from it. And then I pursued a master's in upstate New York at SUNY Albany, where I was working in a community mental health substance abuse agency, getting my master's there. And that did it for me. I was like, this is for me. So I was like, let me get my doctorate. This is what I want to do. That's when I applied to Rutgers and I got into their PsyD program. And I really focused on adolescent substance abuse under this mentorship of Barbara McCready, who was researching evidence-based treatments for alcoholism. And she was mostly on women specifically. She did a lot of research around the uniqueness of women alcoholics and how their lives progress in that way. Lo and behold, I needed a job at some point. So I was kind of like in this lane of like substance use. I was really interested in adolescent prevention of substance use and evidence-based treatments of adults in this area. And when it came time for a job, I wanted to come back to the area of Philadelphia. At the time, my girlfriend lived down here. We had met when we were here at Villanova. So I was looking for a job in the Philadelphia area. And Edna Foa was doing a remarkable study on the comorbidity of alcohol dependence and PTSD, and whether or not you could treat them at the same time, like have a concurrent treatment approach, or if you really needed to kind of sequentially address the alcoholism first, get that under more manageable control, and then wade into the waters of PTSD treatment. This had not ever really been tested. So I had the alcohol experience side. She was the PTSD expert. So she was willing to take me on as the alcohol person and train me in the prolonged exposure side of her area of expertise. So I didn't come into this as like a PTSD kind of person. I really came at it more from a substance use area of interest, and then through this research project, develop the expertise not only in PTSD and exposure therapy, but then broadly speaking, the course of anxiety disorders as well. And I spent 12 years working there, so really took on the breadth of like Edna Foa's research and her legacy.
It's so amazing how people's path, like each step kind of illuminates the next step. You probably didn't, right when you were first starting your studies, you didn't see this final product, but each thing led you to be where you're at to improve so many lives.
Yeah, it was like totally not on my radar that I was going to become like an exposure therapist. That was like not in my mind at all. I was really focused on this passion of adolescent substance use and lives and trajectories and how can we make an impact there. And lo and behold, like as you start to progress and learn, then all of a sudden I started to see like, wow, there is this other very common, unique comorbidity. And I had personal experience with this. I just was more focused on the addiction side of it. But the trauma that comes also with a substance using lifestyle, they really do kind of fit together and come together quite often. I just wasn't as focused on the kind of trauma path into substance use disorders. And it was my work with Edna Foa that really opened my awareness and ideas to this comorbidity, the uniqueness of it, and the challenge of really addressing these two problems at the same time. From a field that had decided without much research that you couldn't do that, that you had to address substance use first before you waded into other mental health disorders that were co-occurring at the same time.
But part of the reason people end up using substances is because of the mental health. So it would also make sense to, if you treat the underlying cause, maybe then the substance abuse would be easier to treat. Again, but this is not my area of expertise.
No, you articulate a totally valid hypothesis, right? And from like, even if just like a reasonable person is thinking about that, that makes a ton of sense. Yet our systems aren't designed that way. Our systems have bifurcated this process, right? Like you have substance abuse treatment lanes over here, and you have mental health substance use lanes over here. And the two don't necessarily intersect, talk to each other, or communicate across them very well, despite this obvious, nature that the two go together, but the systems don't. So we have this real dilemma of the reality of the disorders as well as the reality of our healthcare system.
Yeah, and having, I've spoken to a few addiction experts specifically there on that side of the field, kind of like where you started, and they say addiction is a solution. It's not a good one, but it's a solution to whatever pain that they're feeling. And so
100%.
I love that you're bringing this together.
Absolutely. Just like thinking about the traumatized human, for folks that don't kind of really know and or can appreciate the devastation that this causes. If one could think about the worst day of their lives and then having to almost relive that day on a daily basis through intrusive memories, through nightmares, through bodily memories, through emotional upsetness, like it is haunting you on a regular daily basis. The past can't be gotten away from. And so this idea of substances to help mitigate that, to help suppress those thoughts, to help numb those feelings, to help me fall asleep at night makes complete sense to me, how you would wade into those waters.
Yeah, instead of looking at it with judgment, because that's how we often do with substance use, look at it with compassion. They needed a treatment with efficacy. Now, certainly this one has more harm than efficacy, but you have other solutions that don't have all the downstream consequences of alcoholism or substance abuse.
Yeah, it's such a shame that the short-term solutions of the substance use are so impactful
Yeah.
and effective, to be honest with you. Like there's
Yeah.
there are few things, medicines, let's just call it, as effective as something like alcohol or an opiate or a benzodiazepine. The short-term effectiveness of those medicines are really hard to get out from underneath of. And then obviously the longer term consequences of them eventually become apparent. But the effectiveness in the short term, if we could be as good with our medical treatments as the short term effectiveness of those substances are, we could fix a lot of problems.
Be a different world.
Yeah, it would be a different world. So to your point, compassion for
Yeah.
understanding how people are trying to survive and make their lives better in the moment. God help them that they're not thinking about a year from now. They're just trying to get through today, and they find a way to do it, and a really, effective way to do it. It just brings these other problems in the long term that now we actually have to address both of them instead of one or just the other.
Yeah. So ideally, we'd like to catch people earlier in their trajectory so we can give them these treatments that are effective, give them these tools that they can use lifelong.
Yeah.
And so let's start diving into some of the tools. I'm not going to lie, prolonged exposure therapy sounds terrifying. It's like
Yeah.
being chucked in an ice bath or covered in a pile of spiders. So let's unpack some of the myths around that.
I love that. It's, when I was with Edna and working with her, we often talked about how she actually came up with the name. And she wishes she had come up with a different name because the marketing of it is really bad. It's not something that like is warm or soft or compassionate, or like it doesn't draw you in, with care and compassion. It's more aggressive, right? It's exposure. And so we have a branding problem when it comes to our interventions. We do not have an efficacy problem, by the way. We happen to have a tremendously effective treatment with an awful name. And so it creates a barrier right there. So I appreciate that idea. And like, look, the ultimate nature of PTSD, and years ago, it was housed under the class of disorders called anxiety disorders. More recently, it has been moved out of the anxiety disorders and into its own kind of trauma-oriented set of disorders. And that was important because it broadened the base of PTSD from being a dominant fear-based driven disorder to something that's more complicated emotionally. There's fear and anxiety, but there's sadness and guilt and shame and embarrassment, anger. It's a much more emotionally complicated disorder than just fear. And
That's a lot to carry.
A lot to carry. And then that's just emotionally. Don't forget about physiologically. You're talking now, your heart starts racing, your stomach drops out from underneath you, you get sweaty, you get panic attacks that run over you. So you have this physiological and emotional overwhelmedness that's happening after a trauma and living with PTSD. So it's like your entire body is basically under this kind of threat that happened in the past and that you can't get away from in the present. So, treatment for this is extraordinarily important. It is a devastating, debilitating disorder.
It is. And I know that there's a lot of awareness around military, and God bless our veterans. They have a lot of it. And they are not the only people. I've heard people who have had a traumatic birth delivery process, an illness. So what are the ways that people can get PTSD?
Yeah, great question. It is not only via combat. This is not just a disorder of veterans and active duty military and soldiers, even though they're the ones we think about and they're the ones that, we obviously are caring a ton for. But combat's one path into this. Violence, though, of kind of any nature is a path into this. So people who have had car accidents, people who have been mugged or assaulted or in a fight, people who have been sexually assaulted, children who have been molested or, abused or neglected or bullied. All of these are pathways into the disorder of PTSD. And like, if you're a human, you're vulnerable to this because humans aren't always kind to other humans. And the way in which, and particularly interpersonal violence, is one of the most likely producers of PTSD. The number one experience that leads to PTSD is rape, sexual assault. 1 out of 2 women who have survived a sexual assault go on to develop PTSD symptoms after that assault. So that type of interpersonal, intimate violence is really the driver of PTSD symptoms. The least likely type of trauma are natural disasters, like hurricanes, tornadoes. They're not person-to-person violence. And so they're the least likely type of trauma to lead to a PTSD diagnosis.
Oh, that's interesting. Okay. But yeah, I can see that person to person because it feels personal. It's a more direct violation of you as an individual.
Yes, we can appreciate that nature is unpredictable, that
Oh
nature
yeah.
can be violent, that nature can be devastating. Our minds are able to make sense of how nature can do that. It's a lot more difficult for our minds to make sense of how one human being could do that to another human being.
And
That
when it's someone who's supposed to care about you or love you or keep you safe, it's just very hard to wrap your head around how could
completely,
they do that?
completely. Yeah.
Okay.
When you have those types of interpersonal violence situations, you become very vulnerable to the sequelae of that violence. PTSD being one path that follows out of that.
Okay. And so, say people have experienced that either recently or even in the faraway past and are experiencing either anxiety and or PTSD or one of the pathways that manifests. So you said there's treatments that have efficacy, which means they work. That's
Yes.
the most important thing, right? Because it
Yes.
can be very frustrating to think that you're stuck like this forever because that just adds to the stress. But there's a huge light at the end of the tunnel. There are things that can help. So let's talk about that.
Yeah, I would argue there's at least 3 highly effective treatments right off the bat. Other people will tell you there's a lot more than that, and they're probably correct. But 3 of the top best: prolonged exposure therapy, cognitive processing therapy, and EMDR.
Cool.
These
Let's
3
talk about
treatments
it.
are extraordinarily effective in treating the symptoms of PTSD. I am a PE guy, so I
Yeah,
really
yeah.
stick to the model of prolonged exposure. And the conceptualization from this is, I think it's pretty clear and straightforward. After a trauma, if anyone has been in, a lot of us have been in car accidents. And so I often use that as an example because it's relatable and it was scary. And so we know what it's like after that to be afraid and to be scared of something bad happening again. And it often leads to behaviors to want to avoid the risk and the danger of going back out into the world. And so that comes up in 2 ways. You can avoid the things out in the world, people, places, things, objects, etc. And we can avoid the internal reminders, which are our memories, our bodily sensations, our emotions. They get all connected to the event. And so 2 ways in which we respond are very often to avoid the memory of what just happened. And so very commonly, people with PTSD, one of the things that they are really good at doing are avoiding the reminders of what happened. And so it's through these avoidant behaviors that the maintenance of PTSD, the development and maintenance of the disorder, arises via a dominant coping strategy of avoidance. I don't want to think about it. I don't want to feel it. I don't want to remember it. And I certainly don't want to be in a situation where it could happen again.
And it's that avoidance that leads to it lasting so long.
Yes. So as
Ah,
long as avoidance continues to dominate the landscape of coping, when you avoid something, what are you fundamentally, not doing, right? We're not addressing, we're not confronting, we're not dealing with what's there. That's why avoidance prolongs and keeps the disorder alive. And that could be for decades. Think about Vietnam veterans.
yep, absolutely.
We're talking going to be 50 years later, and there's many folks who are still living in the memories of that past, or a child who was abducted or molested or raped for decades. That effect can linger for them. So this is not something that just goes away.
Yeah.
It will linger, and this is why people also feel it's not treatable, because it just keeps going on and on and on.
Yeah.
Um,
If
and
they've had it for a long
unfortunately,
time, they probably feel like they're stuck with it forever.
yeah. And they've tried things, they've gone to therapy and or they've tried medicines, and it hasn't been super effective. So they
Mm.
become hopeless too. And one of the hardest things is getting consumers, mental health consumers, access to these three treatments. Like if they could get access to PE or CPT or EMDR, they really might have a different course of illness. Um,
Wow.
but they don't. It's very hard for these folks to get to a practitioner who's going to provide that evidence-based treatment. So let's just go back a few steps, right? Like
Yeah.
for me, avoidance is the disease.
Okay.
That's the real nature of the disorder now, is the maintenance through avoidance. So you are correct. Exposure sounds terrible, because if the disease is avoidance based, the cure, logically in my mind, ought to be approaching the things that we're avoiding. And
Yeah.
therefore, PE is all about approaching trauma reminders, the trauma reminders that are outside from us, as well as the trauma reminders that are inside us. And so we use two types of exposure, one called in vivo exposure. So that's in life exposure. Let's just go back to being in a car accident. When you've been in a car accident, you don't want to drive. You don't want to be around the place where that car accident occurred. There are smells or sounds or just memories that pop up. We approach those reminders. Then there's the memory side of what happened. And we call this imaginal exposure. And
Mm.
that's where we talk about what happened in a way to try to make sense, to process, to digest the event that occurred, and to try to come to some new meaning over what happened. If we never talk about it, we can't change the meaning associated with it. So prolonged exposure is really taking these two ideas of, let's approach the reminders in order to learn that reminders about something in the present from the past aren't necessarily the same as they were in the past. A smell, a sight, a place, a person, whatever, in the present may not be the same as it was 2 decades ago. But if you don't approach, you will never learn that. So that's, in essence, what PE is about.
Okay. So
Discovery.
this isn't just gratuitous, shoving it in your face, forcing you to relive it. It is allowing you to process and digest it so you can have a different interaction with it.
100%. This is fundamentally about changing your relationship with an experience from the past. And the only
Nice.
way to alter your relationship with that experience is to spend time with it. And so exposure this is why it's a marketing problem. Like
Yeah.
it carries this, very scary thing. Like, you're going to make me do this or that. I'm not going to make anyone do anything. We are going to collaboratively work together in a way to help you approach things that are fundamentally safe. Nothing is a
Mm.
guarantee. I'm very aware of that. There's no promise that just walking across the street is going to go well. And all of us walk across the street and take that risk on a regular basis. So this is about going back to taking everyday risks that are required of us as human beings to navigate the world. And we are just trying to help them remember and relearn that they are capable of taking those everyday risks. So we're not making anybody do anything. And we certainly aren't making someone do something like really scary or frightening. I often use the term of like going to a zoo. When you go to the zoo and you go to the lion's den, The lions are on that side of the glass and we're on this side. We don't go in the den to visit the lions. That would be dumb, right?
Yes, those
So we
people that
want
try and do it every couple of years just to be famous that get
to
eaten.
dumb,
Yes, that would be
dumb.
dumb.
We don't do dumb things. We are trying to do things safely and to relearn that there is more safety in the world than we currently feel that there is. So
Wow.
exposure is meant to be gradual. It's meant to be collaborative. It's meant to be, we both agree to do this. And there's a rationale for it. We explain why. And these are opportunities that clients have. And if they say no, it's no. That's just the way it
Nice.
is.
So they get to maintain that safety and autonomy of being able to say no.
100%. It's incredibly important that they have the right to say, I don't want to do that. That doesn't feel safe. I'm not ready for it. Whatever that might be. They're in control, which they weren't in the past, which is a huge issue about exposure because the very thing they're scared of is you're going to make me do something that I don't want to do, like I was made to do something before that I didn't want to do. And we
Yeah,
are
wow.
not replicating that. We are actually empowering clients to make choices for themselves, for them to learn that this is doable by me, and I don't need anything else other than me to get through that.
So there are people out there listening who have experienced PTSD or have a loved one who have had some type of trauma. And let's be honest, we don't all process everything with the perfect level of coping skills, right? But they maybe, like you said, maybe they've tried a few therapies or some medication and it didn't work. So they're kind of stuck in this state. But you're saying this prolonged exposure, again, the name, not necessarily the best, but they are guided through this. They get the foot on the brakes. They get
Yes,
to decide.
all the time, 100% of the time. And I like when you were just saying that, the thing that begins to pop up in my mind as a person kind of lives with this PTSD and they start to see it persistently. It's not responding to, a medication or even like a general, more talk therapy type of scenario. This is when I want to nudge like really smart consumerism for shopping for quality care. And, and so if you look at clinical practice guidelines for PTSD, the VA, the Veterans Administration publishes them. The American Psychiatric Association has them. The American Psychological Association has them. The National Institute of Health, they're all over the place, right? Every clinical practice guideline lists prolonged exposure, cognitive processing therapy, and EMDR as evidence-based treatments for PTSD. If you are out there and you have not had one of those interventions, this is the time to find a provider who knows what they're doing in that space.
Yeah, I mean, for so many separate bodies to all have this consensus. This is not a fringe treatment. This isn't something you made up like in a van that you drive around in. This is an efficacious treatment. And the frustrating thing, and you and I both share this frustration, are the barriers to accessing it. So one, we talked about the name, right? The name sounds scary. People are like, I don't want to do that. But when
Yep.
you know the benefit you're going to get, so what other barriers are there that are keeping people from getting access to this?
I was thinking about this recently, and I'm coming to the conclusion that people in my shoes are the problem. We, the
Oh,
clinicians, the therapists, are a big part of the problem. And so there was this interesting research that was done. This guy, Brett Deacon, he's over in Australia now. He's an American, but he's got a nice career going on in Australia. And he came up with therapists' beliefs about exposure scale. And he started to, deploy this scale to all kinds of therapists. And what we started to find is that therapists have a pretty significant belief system that's anti-exposure interventions. They're scared about it. We have our own anxiety ourselves, and the idea of approaching something that scares us. And we're not as likely to want to do that with our, clients when we're nervous about it ourselves. And
Oh, wait, you're saying therapists are humans too? What? When did that happen?
unfortunately, very human and very susceptible to the same problems that everybody else in the world is. And look, and I believe this to be true, that we ought to be a set of empathic, compassionate human beings as well in order to do this job. And so, just coming back to the marketing problem of exposure, we don't love the idea of purposefully approaching things that cause distress. We don't want to cause more harm to our clients, to our consumers. And there is this persistent belief that exposure can be harmful to both the consumer as well as vicariously to the provider.
Mm.
And this belief drives a lot of the angst against utilizing exposure-based therapies, despite the research evidence that is undeniable. These things don't get into clinical practice guidelines if they're dangerous for anyone to deliver and or receive, right? Like, that's not how science works. That's not how medicine works. That's
Is that
not
how guidelines work?
not how it works. So this isn't a rational problem, in my opinion, right?
Ah,
This is a fear-based problem about believing something that might be true despite the vast amount of evidence that says it's not. And so what it comes down to is clinicians needing more support and experience in order to learn how to deliver exposure-based interventions correctly and appropriately so that they can see the benefits of them themselves, so that our anxieties about causing harm to someone or to ourselves can come down and we can feel the confidence of the data, of the research, of the evidence versus our worries about that, which right now, unfortunately, I think are dominating the choices that are being made on the clinical side. There's something like 1 out of 9 presenting mental health problems would benefit from exposure-based therapies.
wow. I mean, if you were looking at saying 1 out of 9 people coming in would benefit from a medication, we'd be all over that.
Correct. I wish we had the budgets of pharma.
Yeah.
We could like really
Oh,
promote this out there because these interventions, and I don't want to disparage medicines, they've helped
of
mental health,
course.
tremendously. And exposure-based therapies for anxiety disorders, for trauma, for obsessive compulsive disorder, they are some of the most effective treatments that exist for human beings. And they are some of the least utilized interventions
Wow.
for anxious people. It's a real discrepancy between the evidence and the science and what the practice is.
So we need that's part of what we want to do here today is try and close some of that gap. Now, at Navigating Hope, we talk about green flags, red flags, right? Not just with dating, of course, but
Yeah.
looking. So somebody is listening to this and they think, okay, I would like to explore this, but I want to find a therapist who can do this correctly, safely, with efficacy, as opposed to somebody who took like a 2 hour course and they're going to traumatize me. So
Yeah.
how do we find someone like you, or even you, like you, because I know you see people
Yep.
virtually? How do we as consumers with mental health needs find the right person?
Part of it is going to start with like some good education. Like, what's my problem? Is if we kind of know what your problem is, then we can start looking at, well, what are the things that address that problem? So if we're talking PTSD and we are at least aware now that I know my problem is trauma and PTSD. Now let's look at what are the evidence-based treatments for that disorder. Let's just do a quick Google search, right? Like PTSD effective treatment, boom, comes right up, right? Right there. Fine. Prolonged exposure, cognitive processing, EMDR. Now at least I know what I'm looking for. Now you got to find the person. And here's where it starts to get it. But you got to know what you're looking for first. So I'm looking at places like the Association of Behavioral and Cognitive Therapies. It's called ABCT. They have a find a therapist function there. Anxiety and Depression Association of America. They have a find a therapist function there. You're looking for bios that have training and experience in prolonged exposure therapy. When you meet your provider, and this is like you're a medical doctor, like we have this reverence for you guys, less so for maybe psychologists, but they still call us doctor. And so they defer to us. But interview us, please. Ask us, what do we do? How do you do this? How often have you done it? What was your training? Did you get supervision? Like, grill us, interview us. This is your life on the line. I expect to be asked questions about my expertise and whether I know what I'm doing or not. And I'm very rarely asked. So part of me on the consumer side is nudging mental health consumers. You wouldn't go buy a car or something, substantive without asking questions and really questioning the person you're dealing with. Don't do that with your medical care. Ask questions.
Yes. And one of our red flags that we talk about is if you do ask those type of questions, if they are defensive or angry or deflect, that's concerning. Like,
Walk away.
People ask me where I train. I'll talk about it all day.
Walk away. If
Yes.
you're the defensive person who doesn't like your questions or whatever, this is not the provider for you.
Yes.
Yes.
Oh, fantastic. We are so aligned about that.
That's a great red flag. I'm so glad that you brought that up.
Yeah. Oh my goodness. Fantastic. And we'll get at the end of this, we'll give people a checklist, red flags, green flags, because I think that is really important. I work in the ER. People don't get to choose me. They, come in bleeding and they get who they get. But I'm even in that situation. I'm surprised when people don't ask questions before they leave. And so I give them the nudge. Hey, if you were my aunt, I would encourage you to ask this. So let me go ahead and just answer that for you.
Yes. 100%. Like that's, as a consumer, what you're really looking for a provider who's actually just also willing to just start telling you, here's how I would approach this. Here's the research evidence for the treatment that I'm offering you. Like, it should just be given.
Yes.
So if it's not even just given, you should already know I'm in a little bit of a red flag space because this person isn't just offering that information directly to me. Now I've got to ask for it. And then secondly, if you ask for it and you don't get it, now you got double red flag, walk away.
Yeah. Oh, time to go. That's like you're shopping for a car and you've got 2 flat tires. Stop trying to drive that.
Correct. This is not for you.
This is not for you.
Yep.
Now so PTSD, that's certainly, unfortunately, probably a fairly large portion of the population, but there are people who have things like OCD, or maybe they don't identify with any of those, but they feel anxious. When there's an election and there's strife in the world and there's just anxiety and you worry your kid's going to get hit by a car. And so kind of just that pervasive anxiety that doesn't fit into the box of those. Yes. Can you help those people as well?
Definitely. We have in OCD, we have a really good treatment called exposure and response prevention. And there's a very good treatment also emerging called inference-based therapy for OCD. It's a more cognitive intervention and less exposure-based, maybe even like minimally exposure-based, but 2 very promising treatments. ERP, meaning exposure and response prevention, has been around for a while. It just so happens that Edna Foa is the main researcher who has developed ERP as a treatment in addition to prolonged exposure for PTSD. So I just happened to learn all about that with her. I was just less of from a clinical interest, I was into the comorbidity of substance use and PTSD. So I spent a lot of time there. But our clinic was oriented around OCD. We ran research studies treating OCD. So we treat that with a very similar exposure-based approach, and it happens to be very effective for those consumers who can really receive and follow the plan. Very effective. Doesn't work for everyone, but is highly effective.
Ooh, that was a big green flag for me right there, that you said it doesn't work for everyone. Everyone who has, anyone who says they have a magic wand and it'll work for all people in all situations is so red flaggy for me. Yes. And just in the natural course of your conversation, you recognize there's individual differences and it doesn't work for everyone. That was, I love that.
The averages are fantastic, right? Like, we're looking at research studies, we're seeing on average significant results, right? But they're averages, they're not individuals. So when you start looking at individuals, you're going to have a variety of paths open up in front of you. But if I'm an individual, I would like to take the path on average that produces the best result. And
right? Me too.
so OCD, another really difficult disorder is called panic disorder, where
Mm.
you're overwhelmed by fears that your body is going to do something to harm you or hurt you, like have a heart attack and die, or just go crazy and lose control. So it leads to a ton of other avoidant-based behaviors. Social anxiety, where just talking to people is super scary because I'm going to be evaluated and judged and critiqued and criticized in ways
Do you
that
feel like that went up after we were all on lockdown and stuck home and then we started interacting with each other again? Just
super
based on
hard
my very non-scientific, it seems like people are more socially anxious than before.
and or socially like just ineffective. Like we've lost social skill. So
Yeah,
we've both emerged more anxious and less skillful.
you're right. It's a bad like put down your phone and interact with people. We got to do it.
Correct. So like that has totally kind of built these like fences and barriers between us and other people. And then all of a sudden somebody comes in across our barrier and then we like don't know what to do with them all of a sudden.
Yeah.
No.
My
So
goodness.
yeah,
And
so like so many of the I had a client who had this phobia. I've treated a bunch of phobias: dog phobics, spider phobics, snake phobics, height phobics. But there's this unique phobia called emetophobia, which is a fear of vomiting.
I was looking at that on your website, and I'm not going to lie, I have a hard time relating to that because I puked through 2 pregnancies,
I
literally
bet.
from the time I peed on the stick until I gave birth.
Yeah,
So if I had any fear of it, is I had prolonged exposure, but not
you
in a good
did.
way.
Correct. No, you have satisfied that dilemma by being
Yes,
pregnant, which
but surprisingly, I know I hadn't thought about it before because I figured flying, public speaking, spiders, in case is not clear, is my phobia. And I was shocked. There's a lot more spiders are awful, but a lot more people had the emetophobia, the fear of vomiting, than I had any idea. And then I started just kind of chit chatting with some of my friends and even family members, and like, oh my gosh, I'd rather do anything than puke. And I'm like, what?
it's like super interesting because women are
Oh,
significantly more affected by it than men, and
interesting.
it has some degree of doing with disgust and control, right? Like
Oh,
I don't
okay.
want to, my body is gonna kind of take over and lose control, and it's gross. Like few people enjoy the process of like
True story. I did, despite the fact that I had so much experience at it, I never enjoyed it.
yeah, it's not one of those things where most of us are looking forward to the next opportunity to engage in that. My point about that is like one of the more common disorders that people don't talk about. And it's shameful and embarrassing because like it's throwing up. Like it's not like all of us have done it, we do it, but to then come forward, everybody, I'm with you, by the way, with spiders, like not my thing.
They're the worst. Oh my God.
Like,
Put me in a room full of snakes. I'm fine. You show me one little spider and I'm like, I gotta go.
and everybody's okay with that. Like if you go around telling people about spiders or snakes or heights, people
There,
are accepting,
I have
they get
no
it.
social consequences whatsoever.
But you start saying you're afraid of throwing up, and people are like, what's wrong with you?
Yeah, why are you being weird? Yeah.
Yeah. And so no one talks about it. It stays
Mm,
secret. It's shameful. It's embarrassing. And it goes under the radar.
interesting.
Um, but it happens to operate extraordinarily like OCD. Because if you're afraid of throwing up, what causes one to throw up? Bugs, germs, stomach flu, whatever that is. And so if that's one of your main pathways into that, then you have to start getting super clean. You have to start washing everything, avoiding dirt, germs, bugs, people, all of that stuff. It gets debilitating quickly.
How interesting. I didn't even think about all the consequences associated with it.
100%. Yep.
Yeah, my pathway was pregnancy. So
And so like the same type
most
of
people, if you're
process.
going to vomit, you're right. It's because of a bug. I see them in the ER. They're vomiting. They have diarrhea. They're miserable.
Totally. Right. And so no one wants to go through that.
Ugh, no.
So if you've got a phobia in that area, you will go to extraordinary lengths to not have to deal with that. And that's what anxiety disorders, broadly speaking, are fundamentally about, the extraordinary lengths that people are going to in order to prevent something from happening that they don't want to see happen. The question always, is it really necessary to go through all of those hoops to prevent this from happening? And even if something were to happen, would it be nearly as bad as what your imagination is telling you that it is? And that's why exposure therapy is so effective, because it helps challenge those ideas through a behavioral, concrete process. We don't have to think our way through this. We don't have to challenge thoughts and try to see whether they're, identifiable and challengeable and slippery. We don't have to start with trying to change the way you feel. We're going to start with what you do in response to prompts and triggers, because if we change your behavior, we're likely going to change the way you relate to that prompt, to that trigger. And that's the key. Change the way you behave. That changes everything.
And there, oh my gosh, there's so many good things to unpack there, just changing the way you respond. And really, even backing up a little bit to what you said about the actual thing not being nearly as bad as all of the worry leading up to it. And so I went rappelling off a cliff. And I'm very athletic, I'm very outdoorsy, but I have no idea why. Just according to my 12-year-old daughter, this is what she said: yeeting myself off a cliff was not something I did. And so I'm leading up to it, and I'm with a group of super supportive people. Martha McSally's there. She's the first female fighter pilot. I'm like 6 inches taller than her. She's this tiny little, like, amazing badass who's accomplished so much stuff. I'm like, I don't want to embarrass myself in front of Martha McSally, but I'm about to yeet myself off a cliff. And honestly, the actual doing of it, other than like I got a scrape on my leg, it was not nearly as bad as what I had led it up to be.
Correct.
And how we can do that. We can spin ourselves a story. One day, my daughter had said she missed the bus, but then she didn't come back and we couldn't find her. And so, of course, in my head, immediately, she has been kidnapped and trafficked, because I do a lot in the human trafficking space, as opposed to the fact that the bus came a minute later and she was on it and she was safe and she was fine.
Yes.
So do you have some practical tips for us when instead of spinning out into that story, or that creating the thing to be so much worse than the doing? What are some things that us normal humans can do?
One of the things that's great about people are our imaginations and our
Oh boy.
and like oftentimes that can be used for, great and good and lots of positive things. Sometimes it can be used for evil. And the anxious mind can go into its imagination and come up with stories that are awful. And once that story becomes somewhat repetitive, there's this concept, right, of like the narrative becomes the reality. And so if you are telling yourself this story over and over and over again, you have now created this to be real, even though it's never actually even happened yet. And so one of the things that I'm asking folks to come in with is to be aware that they've been telling a story for a long time. And they don't question the story anymore. It has become reality and truth. And what I'm asking them first to go back to is to say, what if you're wrong? How will you know? Because you're operating as though you've nailed this and you're 100% right about it. And you have to do these things in order to prevent this guaranteed future from happening. But what if you're wrong? And so that to me is usually the space that we're trying to create. And so I'm nudging people to question themselves. What if you're not right? How will you know? Are you testing your beliefs? Can you turn this into a hypothesis, not a fact? And if it's a hypothesis, how would you go about seeing whether it's true or not?
Yeah, and testing beliefs is really important. I teach my kids to experiment, and even in the kitchen, like, how do you know a cheese Oreo is disgusting? Have you ever tried it? Now, spoiler alert, it was, but they tried it, and that's kind of the point, right? You've got to see if it's actually true. And so I'm very much the kind of parent, and my husband too, where instead of, they ask us, okay, how do I do this? And we suggest, why don't you try a few things and see what works? Because you don't know until you try it.
Correct. So exposure therapy is just terrible, right? But we could call it behavior therapy. That might be a nicer kind of, because what we're trying to do is like, let's try something else and see what happens.
Yes.
Anyway.
A mentor told me a while ago, and I can relate to this because I'm in Michigan. I mean, you're in Pennsylvania. We see snow, right? Yeah. And if you've ever gone sledding down a pristine hill where you're the first sled down, you can kind of go in any direction. But as the day wears on, and every time you keep going down that same groove, it gets deeper and deeper. And our thoughts do that too. And so I try and interrupt before that groove becomes so ingrained.
Yeah. You have intuitively identified one of the kind of theories behind exposure therapy. This woman, Michelle Krask, writes about what's called inhibitory learning theory. And part of what she talks, I break it down into very simplistic terms. It's not this simple, but you're talking about a superhighway. You're creating a superhighway, and we do that in our minds. And so we have these fear-based learning that gets repeated over and over and over again. And now, whenever we approach something that even resembles what we're scared of, we immediately dump it into that superhighway and we act accordingly. And so what exposure therapy, behavior therapy is trying to do is to create a competing highway that's talking more about safety versus risk. And you have to create this competing highway to start to challenge the other one. And so you have nailed this idea of a groove and having to get out of that groove by creating a new groove.
Yeah, because that's really important, because what the deeper that groove gets, it sure is really easy to just fall right down it. So
super easy, which is why also the chronicity of these disorders persists, right? Like what's true about this highway is you can atrophy it and you can shrink it, but it doesn't ever disappear. You can also revive it. And if you continue, if you go back to old habits, if you go back to old behaviors, that highway comes right back online. And now the competition is alive again. So relapse and recovery, they go hand in hand. We're really trying to teach folks to adopt a whole new way of living, one that takes on kind of an exposure-based lifestyle.
nice. Well, as we wrap up, I mean, this is a super fascinating discussion. There are so many ways that we can help so many people, and I'm so excited to share this message. So for those of us who are our parents or are reparenting ourselves,
Yep.
trying to develop new pathways, what are any other tools or techniques that we can strengthen ourselves with before a bad thing happens, so that we can go into it, as strong as possible, and then know to get help immediately afterward, just to prevent this prolonged course?
That's such a good question.
There's a lot of weight to that. That might have been a little.
So, one of the things that we've learned, first of all, like something like post-traumatic stress disorder as a diagnosis, it didn't even exist until 1980, which is really only 44 years ago. That doesn't mean the disorder didn't exist. We just called it all kinds of
course.
things, right? But the lane of PTSD as a disorder didn't open until very recently. And by the way, our Vietnam veterans are the reason that came to be, and another reason to be grateful for their service and their advocacy
absolutely.
in this area. But the research around this didn't start until about 1980-ish. One of the things that they described PTSD is it's an extraordinary circumstance, meaning you were exposed to something that most of us won't ever experience. That's not true. That turns out not to be true. It actually turns out that the majority of us, unfortunately, in our lifetimes, will experience a traumatic event that meets the definition of what we call criteria A. It's a traumatic event by definition that can lead to the experience of PTSD. It's something like 60% of men and 3% of women will experience a criteria A trauma. So one of the things, just as a preparation side that you're highlighting, this isn't a nice idea, but the idea here is something like this is likely to happen. So we should be prepared for it. It's not an extraordinary event. It's life, and life is traumatic. And so we should be preparing ourselves for something dangerous and frightful to occur. It's gonna happen. That mindset already changes things. Instead of being shocked and surprised by something that happens out of nowhere, we have a mindset of one of like, oh, this is what they were talking about. And we can be talking about since we know that these things happen, we also know that people struggle afterwards. That's a destigmatizing effort in my mind, trying to take the stigma out of a post-traumatic mental health event. That's also very predictable, very common, very normal. Most of us after a trauma are going to experience mental health problems. In fact, 90% of people after a rape have acute stress disorder for at least a month. So mental health problems are predictable and normal. And if that's true, then treatment for them, I would argue, like you wake up one morning, you get a sore throat, you take your temperature. What do? You call your doctor. Let's make it normal to say, oh, I've had this event, I'm struggling afterwards. It's totally normal to then call the doctor. It's
Yes.
okay to call, to get some help, to realize that, like, oh, I've been through something awful. I ought to get help for that. It's
Yes.
okay. So, like, I'm trying to normalize the process as much as possible, because part of the barriers is the stigma, the shame, the embarrassment of needing some help after something awful has happened. I would like to just turn that upside down by saying I would expect us all to need some help after something awful has happened, and to make it readily available for us to, like, pursue that. So,
If it was so destigmatized and so normalized, like a broken leg, people come to the ER with a broken leg. We're never like, oh, what a loser. Why are you here? Right? Like
exactly.
that doesn't happen. We're like, why, yes, that was an excellent choice to come in with a broken leg. Let us help you. And
Yes.
so why do we not treat our brain as
Yes.
kindly as we treat our leg?
You're going to get me on another soapbox, which
Right.
the second bifurcation is the medical,
Oh, Lord.
lane
Yep.
and the mental health lane. And so we've just decided, medical illnesses are okay, mental health illnesses are not.
And it's so bizarre to me. I remember anatomy. It wasn't that many years ago that I was in med school, maybe 2 decades, but whatever. The brain, if I recall, is an organ in the body just like the other ones. It's not a separate being. And it's true, we do. If you sprain your ankle or break your leg, people are like, oh, yeah, that was really smart that you got checked, as opposed to saying, I am feeling very anxious. I'm having trouble coping. I experienced a traumatic event. Why aren't we like, oh, yes, of course, that makes sense that you would get help?
Character flaw.
Yeah. Like
It's
no one's,
a
if
it's a
your femur is
weakness.
sticking out of your leg, no one's like, it's because you didn't try hard enough, or it's because, you don't have enough self-esteem.
Yeah. It's not like, oh, you're weak or your bones are weak. Like, you
Yeah.
weren't disparaged or somehow put at fault for, God forbid, like you develop cancer. People aren't like, what's wrong with you? Like, why
Yeah.
weren't you doing things right? Like, why didn't you blah, blah, blah. But with mental health, the person is blamed for having the disorder. They're called weak or just not strong
Yeah.
enough, or their will isn't good enough, or something like this. And so that difference in perception to me is really what drives that reluctance to go get yourself checked out, to go see the doctor for something that's really an illness is happening. And it's no different in my mind than any medical disorder that's occurring. I mean, this is healthcare, and I would love healthcare to encompass both sides of what we're talking about. We have a real problem with mental health care across the globe, but in our country in particular. And I would love mental health care to just be healthcare. They belong
Yes.
together.
Hallelujah. Dr. Yusko, this has been incredible. I definitely feel a second episode coming on. This is
It
uh,
was such a pleasure talking with you. I love, like, your enthusiasm and your questions and your curiosity. I wish more physicians brought this level of interest into the mental health space than is currently going on out there. You're doing a great job.
well,
Thank
thank
you.
you. And you too. What we're trying to do together is just break down barriers so people can access the care they need so they can live the lives they want to live.
Could not agree more with you. I'm in on that project.
Yes. Awesome. Well, thank you. Thank you again. Let people know what is the best way to get a hold of you if they are interested in getting some therapy for themselves.
Yeah, please come and visit our website, centerabt.com, www.centerabt.com, Center
And
for
that'll be in the show
Anxiety
notes
and
too.
Behavior Therapy. We're located in the suburbs of Philadelphia, but a very cool byproduct of COVID was telehealth. And the system has created a telehealth license, which allows us in certain states, it's called PsyPact, allows us to see clients not just in the state of Pennsylvania, but if your state is a PsyPact state, we can do telehealth across state lines. Located right in Pennsylvania. Anybody in Pennsylvania can find us, and more than happy to try to help you guys out.
Excellent. All right. Thanks again, everybody. Stay tuned for the key takeaways. And Dr. Yusko, thank you again for your time. I really appreciate you.
No, thank you.
Thank you for tuning in to today's episode of the Navigating Hope podcast. Our guest today was Dr. David Yusko, a nationally recognized expert in prolonged exposure therapy for post-traumatic stress disorder, commonly known as PTSD, and an authority on treating anxiety disorders such as OCD, panic disorder, and social phobia. Dr. Yusko shared powerful insights on trauma, PTSD, and how exposure therapy can transform lives. Let's dive into your top 5 takeaways from this episode. Number 1, understanding the true nature of PTSD. PTSD is not just a fear-based disorder. Dr. Yusko explained how it encompasses a wide range of emotions like guilt, shame, and anger, making it emotionally complex. Understanding the full scope of PTSD can help broaden how it's treated and approached. Number 2, the power of exposure therapy. Exposure therapy, including prolonged exposure, has proven to be highly effective in treating PTSD. By confronting trauma reminders instead of avoiding them, individuals can change their relationship with the trauma and significantly reduce symptoms over time. Number 3, tackling avoidance. Avoidance is a core aspect of PTSD that prolongs disorder. Dr. Yusko highlighted that prolonged exposure therapy helps individuals confront both external and internal reminders of trauma, breaking that cycle of avoidance and moving towards healing. Number 4, overcoming the fear of therapy. While exposure therapy sounds intimidating, it's a collaborative process designed to help patients gradually and safely confront their fears. Patients maintain full control over the pace of therapy, ensuring that you feel safe and empowered throughout your treatment. And number 5, barriers to effective treatment. Despite its effectiveness, many therapists are hesitant to use exposure therapy due to fear of causing harm. Dr. Yusko emphasized the needs for more clinician education and support to increase access to the evidence-based treatments for PTSD and anxiety disorders. So if you or a loved one are struggling with PTSD or anxiety, it's time to seek the right support. We're offering a free resource today, Red Flags and Green, and the link in the show notes to download this free essential guide and take the first steps towards healing. You can also visit us at familycaregiverhope.com. Again, that will be in the show notes. Healing from trauma is a journey, and the right treatment can help you reclaim control of your life. Whether it's overcoming avoidance or confronting fears with courage, the road to recovery starts with that first step. Stay hopeful, stay resilient, and as always, keep navigating your journey with hope.
Thank you for tuning into Navigating Hope with me, Dr. Jaime Hope. It has been an honor to navigate the realms of health and wellness with you today. Remember, in the journey toward a healthier life, knowledge is your compass. If you enjoyed our time together, please share, like, and subscribe to Navigating Hope. Join us next week where we'll continue to empower your health journey, arming you with the wisdom to navigate life's challenges and keep the emergency room in your rearview mirror.